Hello, everyone, and welcome to our second April Fool's webinar today. Sorry for the little delayed start. It's nice to see a lot of people who are registered and online at the moment. My name is Stephen, and I'm the project officer for the New South Wales Fall Prevention and Healthy Aging Network. Just to start off with, I'd like to begin by acknowledging the Bidjigal people as the traditional custodians of the land from which I'm presenting today, and also acknowledge the traditional custodians of the various lands from which you may be working or joining from today. And I pay my respects to the elders past and present and recognise the enduring connection of Aboriginal and Torres Strait Islander peoples to country. So we'll get started with our webinar now. So today's presenter is Professor Anne-Marie Hill, who is a Senior Principal Research Fellow in the School of Health and Clinical Science and Western Australia Centre for Health and Aging at the University of Western Australia. Her research interests are in improving older people's health and well-being. Professor Hill has held 2 NHMRC investigator grants focusing on fall prevention and has over 185 publications with over 110 articles on fall prevention. She's a fellow of the Australian College of Physiotherapists, awarded by the Australian Physiotherapy Association, and has over 30 years clinical experience working with older people. Professor Hill has led large clinical trials in hospital, community and residential care settings and collaborates with Aboriginal and Torres Strait Islander researchers and communities focusing on healthy aging for Aboriginal people in Western Australia. In line with this year's April Fool's theme of Let's Talk About Falls, Professor Anne-Marie Hill's talk will cover why communication is a key strategy for hospital fall prevention and strategies for systemic and clear communication between and within staff and patients. Over to you, Anne.
Thanks, Stephen, and apologies, everyone. It was myself who kept you waiting with an unanticipated issue on my Microsoft Teams. So I'm not sure what happened there, but I'm here now, which is fantastic. I'd also like to acknowledge the country I'm on, which is Noongar Boodja, and I work in Boorloo, Perth, WA. And I'd like to acknowledge particularly the Whadjuk people of the Noongar Nation, which is where I am, and pay my respects to elders past and present, and particularly acknowledge the beautiful artwork of my colleague and friend, Dr. Margaret Gidger, that she has loaned me for doing an acknowledgement to country. Let's see if I can get rid of the next slide. Sorry, everyone, it's just a little bit working in a slightly different environment. You know that all research involves funding, and I'd really like to sincerely thank all the teams and people that have funded me over the years. And I currently hold a research fellowship from the Royal Perth Hospital Research Foundation. So I'd like particularly to thank them for supporting my position to continue to do work that helps older people and promote safety. And of course, lastly, anytime you do this sort of research, you're talking about a big team of people. And here's some of our team from the Western Australian Centre for Healthy Aging. I really like to acknowledge and thank them. All this work has been done by them and with them. I'm going to talk a little today about the evidence for patient education, since it does have grade A evidence for falls prevention, and encourage you to think about how you're going to provide multifactorial strategies in the education that you deliver to your patients about falls. The evidence also strongly points out that patients generally aren't aware they're at risk of falls and don't seek assistance. And the evidence tells us that education can raise awareness, motivation, and knowledge. Fundamentally, responses to call bells are important with falls prevention. And the other thing that's important when you're looking at educating patients is having the right environment and making sure that when you audit around your ward, beds are at the right height, brakes are on, bells are in reach. It is still surprising how when you find patients have had a fall, whether their bell was in reach or not, whether their walking frame was in reach. So whenever we talk to patients about falls prevention, the patients to some extent rely on us to have the environment such that they can undertake the strategies and things that we want them to do. So just a very brief overview of the evidence. Of course, what is really important though is how are you going to implement the evidence? And I hope you'll really take away with you today that I'm going to be talking about patients being central to implementation. If you involve patients and make them central to improvements in care with continuous engagement, you will have good effect for your falls prevention programs in hospitals. You do need systemic implementation because you need to drive culture change. It's something we're working on at the moment in wards where I'm doing a trial. One of the things you need as part of that culture change is consistent and affirmative communication by the multidisciplinary team. Everyone being on the same page, giving the same message to the patient and the same message to each other. And lastly, overarching and underpinning everything you do, taking an age positive approach is really important. And I could give a whole talk on that because you need to address ageism in your wards if you're going to have a positive and low, hopefully low incidence of falls on your wards. Why is that last point I made so important? Well, we know now that older people make up about 42% of all admissions. So of our millions of bed days per year, nearly half are for older people. That's only going to increase. So at the moment, older people are about 17% of the population. That's going to increase. And so it's predominantly older people in hospital. And of course, they are the people at highest risk of falls. We know that falls in hospital have serious adverse consequences, and we know that falls are one of the most reported SAC1 events. So, of course, we really want to be sure that we take a focus on how we're caring for older people in our hospital. I would like to tell you that this isn't so, but is ageism alive and well? It certainly is in healthcare. The ageism has found to be resulting in adverse events, resulting in older consumers feeling they're not being listened to, patients feeling disempowered from their care and being involved in their care. And so it's definitely, can I pitch immediately and say, you can go online to this site and find good reports and strategies on how to cope with, combat ageism. And before you even do any falls prevention, it is really important to look at the presence of ageism on your wards because without knowing it and unconsciously, it's colouring the way staff behave. And that in turn is colouring the way that older patients behave on wards. And it's leading to unsafe situations. Here's a paper that we've published that we've talked a lot about and has had very good feedback from our consumers and from places where we've been down to senior citizen centres, etc. We gathered together many consumers through focus groups and individual interviews and talked to them about their experiences in hospital. And interestingly, we asked them about falls prevention. We asked them nothing about aging. But these were the things they said to us. They volunteered these types of comments and information. When we said, how can you be safe? And, how can you prevent falls? One of the things they kept talking about, well, nobody listened to me or no one talked to me about it properly because they thought I was old and I wouldn't know what was being talked about. And you see someone has said here, you get put into that older person category. And some of our patients, consumers commented very strongly about people didn't speak to them and just dismissed what they had to say. It was almost like you get to a certain age and it's all over Red Rover. This was from a patient who, ex-patient, who knew about their condition and was trying to tell the team what had happened to them, and the team was paying them no attention and just sort of saying, well, you wouldn't really know, or dismissing the patient's knowledge of their own health condition. And so that experience of ageism is very strong and has a very negative effect on older people, on their motivation, on their engagement, and on their ability to communicate with you about what they are thinking about being safe in hospital. So as I say, we could do a separate talk and discussion on that, and I really encourage you to follow up on that to develop a really positive culture in your ward of every age counts. Now, everything I'm going to talk about is underpinned by the falls prevention guidelines, and I know that you'll all be really familiar with them. And so they're kind of, in a way, our underpinning guide to the latest information, and help us to audit and benchmark our services. So they're going to form a foundation to what I'm talking about. The evidence for hospital falls prevention is also found in the World Falls Guidelines, and part of the World Falls Guidelines include a systematic review led by our team in Australia. And so really important, it's high quality evidence. And I think what's important for us, and lucky for us, is that we can be sure that the evidence in here really is very strong for Australian hospitals. And there's an element of, because we are talking about Australian trials, then we can feel that they could be reasonably generalisable to states around Australia. In our systematic review, we completed a meta-analysis of our earlier education trials, finding that they resulted in reduced falls rates and reduced falls risk. And these were two large trials, one an individual randomised controlled trial led by Professor Terry Haynes, and one a step wedge cluster trial led by myself with Terry Haynes. So when I started to talk about these trials when we first completed them, some of my colleagues said to me, "Well, what did you do after the education, Anne-Marie? Did you then go and do things on the ward and provide assistance and training and exercise for people?" And I said, no, the intervention that reduced falls was a talking intervention, talking to patients and making sure that we as staff in the second trial provided the right environment and space to help patients enact the strategies that we asked them to do. It's also been a large, very well-cited scoping review led by Dr. Hazel Heng with the team. And that scoping review provided very strong evidence that education is an effective means of reducing falls in hospital. And they're both good articles, which if you're interested, you might like to follow up on. Why do falls happen? Understanding the epidemiology really helps us. We, if possible, need to think actively about this, because it does so much help the way we would set up our culture on the ward. Falls don't happen because the patient has risk factors for falls. So yes, the patient has risk factors. They may have a cognitive impairment. They may have a neurological disease. They may have poor vision. So they certainly can have risk factors. However, one of the things is that the patient's mobility is suddenly altered. So imagine if you went outside after work today to go for your normal either brisk afternoon run or walk, and suddenly found you put your sneakers on, headed off down the road, but your legs didn't seem to work as they normally did. You found yourself out of coordination, you were tripping a bit, you didn't feel like your legs were your own. That's what happens to a patient. It's not that they've got their original risk factors, it's that their mobility is usually altered by their illness. It's led to functional decline. They've got, for example, some kind of infection, they feel wobbly. then they start to almost immediately, when they enter hospital, get lots of extra medications, which have all sorts of side effects for older people. And maybe their own personal walking aid isn't there. So instead of them pushing something along that's normal for them, they suddenly got this a different shopping trolley. So the patient's mobility is very suddenly altered, and that means that when they try to move, there's going to be an issue for them which they need help to reconcile in their cognitive thoughts, and also physically to work out how to negotiate things. Remember that there is now an unfamiliar environment. So how many of us have stayed in a hotel and got up at night and banged our head on the door because the environment is dim and unfamiliar to us? So the patient's now somewhere where it's not their own home. And finally, the other thing that leads to falls are staff actions and decisions, because a patient may need help, and most likely if they're ill will need help to do activities. And the ward culture itself will determine how readily and efficiently all the information and assistance the patient needs is prepared. And finally, we do know that we're always looking at studies that show, around 50% or more of events are related around toileting. So all these different things that happen for the patient in terms of the environment, the staff actions, their own mobility suddenly changing, often coalesce around toileting. So that gives us some clues about the types of education we need to give to patients and the type of tailored multifactorial individual support we need to offer them. We know that falls, we know quite a lot about how falls occur, and we know that falls occur when patients are unobserved. About 80% of falls occur when no one's with a patient. That's one of the biggest reasons for giving patients education, because they're doing an activity when you're not there. So they need to be armed with information. We know that falls occur early, and so we know that you need to speak to patients early about falls. You can't think after it's all settled down and I've done their admission and I've handed over, then we'll talk to the patient about falls prevention. And particularly remember that falls occur early in every new environment. So when a patient comes to your ward, even if they've been in the hospital 48 hours, maybe 24 hours in ED and 24 hours in a short stay ward, if they arrive on your ward, that's now a new environment and they need a good orientation. Again, we'll talk about that. We know that most falls happen in the bedroom and bathroom. So that again gives us our clue about what sorts of talking we want to do with patients and what sort of planning we want to do it as staff. We know that a first fall is often followed by a second fall. The biggest risk factor for a fall is having a fall. So if you have had a patient or have a patient on your wards right now who has had a fall, immediately you need to think, what can we change? What can be done differently? What type of discussion should I have with that patient and their family? And conversely, it is important to remember 2 large audits of the National Health Trust database, the hip fracture audit they do each year, and they have about 5,000 hip fractures occur in hospitals every year. They've found that about 80% consistently of their hip fractures occur on a first fall. So much as we like to think that often falls will not be injurious, in hospital, 30 to 50% of falls are injurious, and we can't afford not to communicate early with patients and consistently with families, because we may only have one chance to get that right. And here's just some data we've done of a big US falls database of acute tertiary surgical teaching and medical and surgical wards in tertiary hospitals in the UK. And you can see that enormous spike there, that the number of falls, the total number of falls in this database, which was about 1,400, I think, the vast majority of falls are happening on about day 2, 3. So falls happen early, and then often actually they have a second spike when a person goes to rehabilitation and starts moving around. But falls happen early in your setting, so it really tells you about being timely. Why is patient education so important? that it's actually part of the standards of the commission. Why is it seen as so important? It's really fundamentally important, and I hope that you'll see why it works so well for falls prevention. We know from our own work that if you give patients education, you significantly reduce falls and risk of falls. And we know that falls rates fall across wards when good education is given, even for patients that don't receive the education. So if you have patients on your ward and you give as many as you can clear, effective, continued education, then falls rates will fall across the ward, and some of the good culture habits you develop in the environment and the setting and the way you speak to patients will transfer itself to patients with cognitive impairment who might not be able to understand the education as well. We've recently revised our falls prevention education. We've got a new suite of resources, and we co-designed our revised version with patients and staff. We include goal setting in this. We call it a plan for patients because they like the word plan. But we essentially show, we've got some videos we show, one's a bit longer and one's a bit shorter, and we've got some booklets and brochures, and we make sure that Allied Health deliver it. In one of our settings, Allied Health deliver this, the physios, but in the trial we're having Allied Health assistants develop it and deliver the initial education. And I don't have time to talk about that today, but certainly what we're ensuring on the wards where we're doing the trial is that as many people as possible receive very specific education. So just to tell you a little bit about the background and why it might be important, I'll go back to our consumer feedback, and we've done 3 studies now quite recently with consumers. And I'll just talk to you a little bit about this study first of all. So when we talk to consumers, we found overwhelmingly that most older people have no conception about falls being a problem in hospital. They don't remember anybody speaking to them about falling. They don't remember there's a problem with falls unless they actually fall. And that's a very strong perception. It's very strong and consistent through all our consumer groups. And this perception's been around ever since Dr. Angel Lee first did a study in it's about 2013 where she interviewed with their team older people in hospital and at home, and they said, well, no, I don't think falls are a problem. If they are a problem, I'm sure someone will let me know, but no one has. So this is an ongoing problem because when she did that study, it was 2013, we interviewed these people in 2024, and we're still finding that older people predominantly, even though there's some patient safety books now and different information, they're not picking up on the importance of falls prevention in hospital. In fact, it's a bit the opposite. Their families and carers are particularly thinking, well, mum has been having these falls at home and mum is very wobbly, but of course now she's in hospital, I can just relax. And the subtext of that, isn't it, is because in hospital, mum won't fall over. So there's a real awareness issue that we need to think about. One of our patients commented, we showed them our videos that we've prepared for the hospital, and this was another very common comment. Wow, I've learned more today from you than I learned in hospital and through my doctor. So many of our participants commented in our focus groups that this was the first time anyone had clearly spelled out to them how you kept safe in hospital, why falls were a problem, and they thought it was amazingly good common sense and wondered why no one had told them about it before. A lot of our patients talked about the concept of, from their perspective, there was nobody to help you. So they don't, what this speaks to, if you think about it as a staff member, is it tells you we think hospitals are very familiar places to us, and we think people will obviously pick up, they should ring the bell and there's lots of staff to help them. But our patients don't think that. They see, and we ask them, many busy people running around doing things. They don't pick up that they have a role or a place and they just think they have to try and manage on their own. And here's this lady who'd had surgery. So she was on a surgical ward, which would have had a very significant nurse-patient ratio. And you can see she says, well, I had a lot of tubes and bottles and it was a bit tricky. She was trying to practice walking around and going to the toilet, but there was nobody to help me. So you had to do it on your own. So that lady felt, well, you just seem to have to manage yourself, which is obviously not what any of us would want for our wobbly older patients that perhaps have had surgery. So you can see there's a gap in communication, because I'm quite sure the nurses on that ward would have been only too pleased to help that lady, but she hasn't picked up that she should ask for help. One of the things that our patients now from 3 big studies have told us very emphatically at focus groups, at individual interviews, and at a big World Cafe we held is that hospitals are very busy places, and you don't call nurses or you don't ask for help because everyone's busy. And you read in the paper all the time that the health system is under great stress. And you read in the paper that nurses don't have enough time to get their work done. So our patients have strongly picked up, somewhat unfortunately for our wanting to make our hospitals safe, our patients have picked up that you should feel, if you're a patient, extremely motivated never to ask for help. Everybody's busy. That's really what our patients have learned. But that's not the message that we want to convey to them, is it? When we ask older people what they think they'd like to know about falls prevention and how it should be completed in hospitals, they themselves suggest that that allied health could be good people to help, because they recognise that nursing staff have many roles and tasks on a ward. They really talk about shared vision, that they really think the doctor should be supportive of whatever they've been given in terms of education and receive the information that the doctor should confirm with them. And they like the idea of it being personalised. They all keep saying it has to be an ongoing conversation. This is our comes from a World Cafe we held, and we talked to older people there about what were barriers and enablers. And they talked a lot about, I really would like it if the staff would wait for a minute when I am feeling well enough and then tell me. But they were very emphatic. One lady we had in a group had fallen over and broken her arm in hospital, and she said, "Oh, I wish that they had told me about safety before I started moving around." That's a big thing for our patients. Well, I was in ED and I fell over because I needed to go to the toilet, and no one had told me that I possibly would need help to go to the toilet. So I just got up and I fell over. Our consumers are very strong that the messages have to be tailored, that the messages are individual. And they liked the idea of key staff members leading falls prevention. They were very aware, and we've had other work like Charlotte McLennan has done their very good work in Sydney about the concept of falls responsibility. Whose is it? And that's what patients felt too. Well, you need to find out about falls, but who tells you? And it's a case of everyone's got a responsibility, but actually is the ball falling on the ground between us? Our patients consistently said they really wanted the staff to assist them to set goals. Our patients were very emphatic and quite anxious about, they said, "Oh, we're often asked about these goals now. There's this new thing of goals, and we know that goal-oriented care." They said, "We don't know what the goals are. We don't know what we should do. We need some help to set the goals." So we can't just say to our patients, "Well, what's your goal for getting better?" Because they don't really know. And the same with falls prevention. They said, "Well, I'm not sure what goal I should set, so I need help." And they also really commented about wanting staff to help them feel confident and motivated. That was a very big point to them. They said, one of our participants described very revealingly, how he waited he wanted to go to the bathroom, and he waited carefully, looking to try to spot a friendly face. He wanted a staff member that appeared to be friendly and maybe had some time for him to bring his request forward, feeling nervous, as an older man, for a younger female nurse to take him to the toilet. So our patients are feeling anxious and looking for a friendly, confident staff member who makes them feel comfortable with doing the actions that we want them to do. In our big workshop we had, this is the sorts of practical steps our consumers said that they needed doing. Firstly, just as we've said, if going to talk to patients about falls prevention, it has to be individualised. You can't just have a throwaway line that you give the patient when they come onto the ward. You have to talk to them about their falls risk, their mobility, their situation. They very much wanted their family to be actively involved, not just incidentally, if approved by the patient. Occasionally that is not so, of course. And they wanted it early. They particularly wanted resources. We know that older people still consistently say that they feel they need some visual, and perhaps like, that could be posters or handouts. They like information that reminds them of what's been said. We can't expect to tell patients all about their risk factors for falls and what we think they should do on a ward and then go away and expect them to remember it all. A, they're not well. B, so there's 10th lot of information they've had that day. They need a clear, consistent message and something simple in their hand that they can read afterwards. Our patients consistently said they wanted to feel empowered, so they wanted someone to say, yep, that's it, you're doing the right thing. And they wanted frequent reminders. At all our meetings we've had, I just want to really alert you today, if you're sitting there as a staff member on one of your busy wards, I know we can think often, we feel as staff, we might feel, oh gosh, I've repeated this to the patient 3 times already, or we might feel, well, the other staff will have told them. But our patients tell us, I really wish staff would retell me because I forget, and I really would like them to remind me often. So our patients are keen for us to tell us the information over and over. We know that our patients have said particularly that they see toileting as a key issue. And this is the same with research internationally on this as well. There's other nursing studies showing that falls can be very strongly linked to needing to go to the toilet. And so setting up a good toileting plan with the patient that allows them to keep their dignity and go to the toilet is very, very important. And to do that, our patients were very keen for staff to get good education about falls prevention and support from hospital management. And the older people in our consumer groups thought that it was very necessary that falls prevention education should be mandatory. They were quite surprised when they talked about falls prevention to find that, they began to comment, well, wouldn't all staff know this? And, if they don't, there should be really good information. So I think that's important. So you're going to talk to your patients early. You're going to talk to them often about falls. You're going to talk to them individually. What I'd like to do is give some very practical information in the next part of the talk. And whilst I can give you sort of systemic and broad information, I've also tried to really include something that I'm hoping you can take away afterwards and start immediately. These 6 steps are what make falls prevention work on a ward for patient education, and yet most of them rely on individual staff actions, not actions that take a lot of time, but actions that help. The first thing is it has to be individualized. So telling a patient, you could be at risk of falls, you are at risk of falls is one thing, but saying to a patient, because your leg is a bit weak at the moment and you're feeling feverish, that may make you feel quite wobbly. That's a completely different statement that makes so much more of a take to patients. So individualized information. It needs to be visible to all. The patient and the staff need to be able to see it. Whatever method you have on your ward, make sure that there's something your patients can see and all your staff can see, and that everyone can see the information you want, and so that your patients and your staff are on the same page. All our consumers consistently say that they really would like patient information to be positive and encouraging. So they really want people to thank them, to remind them to be positive about what they're doing. There'll always be something you can be encouraging with a patient about, always. And so you just saying to the patient, oh, that, instead of saying, have you got your bell? You may say that, have you got your bell? They say yes, and you go, oh, fantastic, that's great. So you've affirmed the patient. You've said to them, excellent, that's the correct thing. You've got the bell in reach. Perfect. That has taken you no more time than if you just said, great, you've got the bell, and went out of the room. You've just said, that's fantastic, good, you've got the bell, ring at any time. But it's much more positive and encouraging. The patients need clear actions. They really need to feel they're clear on what actual tasks and things they need to do. And then this is particularly the next to somewhat the factor of being visible education is important, but coordinating it between staff and reminding patients daily is a systematic action that needs to happen in your ward flow. So you really do need all staff to be saying something to a patient about their mobility and their falls and their general well-being every day in a coordinated way. So you do need to be coordinated. You're going to have it in the digital medical record or wherever you have it. If you've got a care plan at the door, you have to have something that's in there that's really clear about what messages the patient gets and what should be done. And the patient needs to be reminded daily or twice daily and shift-wise. The patient needs to get those reminders all the time. Keep your bell in reach if that's the message for that patient. Make sure you use your walking frame at all times. Call me anytime. Those messages need to get repeated and repeated. Now, we've asked many of our staff too, and we've done some staff workshops about how we should deliver education to patients. And we've done a number of publications on this, so you can read more about them later. And again, what's really interesting is our staff tell us the same thing as patients, that the messages need to be repeated. You need to provide staff with training. You need to involve carers. They suggest that we have force champions on wards, and I know many of you will have those sorts of people, and that you need hospital leadership to help you run that culture on your ward. They suggest that barriers are when patients take risks. So that's a point where we need to re-educate our patients, and that we need to timing. And just what our patients said, the timing is really important. Staff comment on time and resource shortage. And I think it's important that we remember we all need to do a little bit of education at every shift, but we still may need one person to take a role in making sure their interaction with the patient includes the 5 minutes of the actual formal education message. I want to talk to you about orientation because I think it's the first thing when you're going to give falls education. And I put this slide up in a slideshow presentation over 10 years ago, or a version of it. And I couldn't believe that there was still something we didn't do for many years working myself on wards. And it's interesting now that in 2025, this is now in the Australian Falls Hospital guidelines, that we have to orient our patients to the ward every time a new patient comes onto the ward. We have to give them some idea of where the ward is, where they are, where the hospital toilets are, where they will go to the toilet, and understand the workflow and understand who the staff are, and have a picture of what is expected of them as a patient. That is really important because We need the patient to focus on their role. What should they be doing as a patient rather than their stress levels? Because our patients tell us they're sitting there feeling anxious, they don't know what's happening, they're worried, they're thinking about things at home that weren't settled, and now they're thinking about what's happening on the ward. People haven't given them any information. This is not helpful for safety. We need to tell our patients, here's your bed, here's the toilet for you. Now, do you have a walking frame? Okay, you need one. Let me go and get that. Okay, now I'm your nurse for the day. And orientation is really important. The very word of saying, when you see a patient, again, we know we talk about shortages of education, but there's no extra time required to, when you see your patients and go round to your ward this afternoon, you might be doing a late shift if you're a nurse, and you may have a new patient get wheeled into the ward. And just saying the very words, welcome to our ward. My name's Anne-Marie, I'm a physio. You'd be saying whatever you're saying. You are already improving the safety on your ward because you are showing the patient you belong here, you have a part, you don't need to just randomly start doing odd things yourself because you're on a ward. Welcome, you're part of this now. So just using that word welcome is the first step of the orientation, giving patients a chance to see where they're going. So just, again, I could give a whole lecture on that, but I'm just going to mention it. And it's very important that we train staff in how to talk about falls prevention with patients. And I'm just showing you two stills here, but we've made a number of training clips, and the people in the beds there are consumers. They're not other staff, because we really want to make sure that our staff see the training clips we've made. These are real people, and so if we don't explain it well to them, then they're not going to be able to understand us. So, it's important to train people in how to talk about falls prevention with staff. One of the things I'm going to say is the research tells us how important it is. Again, you're probably thinking, when is Anne-Marie going to get to the actual falls prevention? But things like orientation, training staff to talk about falls prevention, and this part are so important to be fundamentally building that relationship with your patient. And saying who you are and what you're there to do is fundamental. Our research shows that it helps to build trust and respect and improves understanding. So saying, hello, my name's Anne-Marie. I'll be your nurse for the day, and in a while I'm going to be talking to you this, and now I'd like to talk to you for a minute about falls prevention. That you've already built that relationship of trust and respect. I'm giving you my name. You can trust this is who I am. I'm telling you my role, and now I'm telling you I'm going to talk about falls prevention. It's much more likely the person is going to now listen and have a feeling of what you're saying, feeling part of the conversation. What I suggest to people is spend a small amount of quality time speaking to each patient about falls prevention. Give them a simple statement about the risk for them and talk to them in plain language about how to be safe. If possible, show posters or draw pictures. Make sure that you give them a brochure and handout. Give them a simple, small amount of information. Like our Safe Recovery talks to people about gives them usually 2 or 3 tips. Your tip is ring the bell whenever you need help. Make sure you tell the staff if you feel dizzy. So give it simple information, repeat it often and consistently. Use the teach back technique. Again, could give you another lecture on this. Encourage questions. That is the biggest thing for our patients. Listen. So say to your patients, how are you feeling? Have you had any falls? Are you feeling strong on your feet? Have you been in hospital before? These are all open questions that can lead the patient. Has someone told you about falls prevention? Ask questions that encourage the patient to answer rather than just saying, ring the bell if you need, and then the patient may have no understanding of what you mean at all by that. Or the patient may be thinking, you're not really meaning ring the bell because I know that you're very busy, so of course I won't be doing that. I think that it can feel very overwhelming. Here's our super pit in WA where they dig the gold out. And of all the hundreds of people that work there, you're one tiny speck in that super pit. And it can seem that, how can you as one single person on one shift talk to patients in a way that makes culture safe? And so it's an enormous task. And how are you as one small person going to do that? But just remember that for every shift you do on a ward, each moment of care is a time that you can talk to patients about falls prevention and other things they need talking about. And it may not take you any longer at all, as long as your ward does have a culture of it has the resources and brochures there and has videos and has, so as long as you've got your basic falls prevention culture and someone's giving the patient the information, it's been put in the care plan, every moment of care you provide to the patient, you can give them practical feedback and you can ask them a question and you can make sure that that super pit of your ward works, even though you're one tiny speck in that ward. I just want to finish by talking about a couple of really simple behavior change techniques, and they may seem very simple to you, and apologies for people who may have done a lot of communication training already. But I just want to point out how simple things can be and yet what a difference it can make if you talk to patients like this. Firstly, goal setting is really important, but patients get very confused if you say, what's your goal or setting a goal. So remember to just say, I suggest that the best thing at this point is just to remember, if you could remember to ring the bell at any time or whatever you think is going to be appropriate to that patient. And that's often an early goal. And say, is that okay with you? Are you happy to do that? So you get that agreement. Even if you've suggested the goal, you get the patient to agree and share the goal. And then it straight away becomes something we're doing together. But then don't leave the room instantly. Once you've just said, okay, I'm going to leave the bell. Here's your bell. Okay. Think about problem solving. So just say to the patient now, put the issue onto the patient and just say, do you have your bell? So rather than just give them the bell, say, all you have to do is say, as you're moving towards the bed, do you have your bell? And that makes them think, oh, I'm supposed to think about where it is. So, and then can you show me where it is? Oh, and then you can just remind them, because remember, they're thinking, I won't call. So you can just say, now remember, if you ring the bell, a staff member will respond. Might take a while, but we'll be there. So you've helped them solve problems. Remember that a patient, again, simple thing, but a patient needs help with the action planning part. So if you say to them, ring your bell, you can just comment as you're leaving the room, anything, any types of things, and it'll be relevant to that patient. But you might just say, now, if you need to go to the toilet or get back to bed, that's the ideal time to ring. Ring me immediately. So you're giving them a clear action. And finally, don't forget framing, reframing. When patients are seeming offhand or a bit down, or the patient seems uninterested or has just gone to the toilet very dangerously, remember to think of a way of telling them to view the goal you've set as positive. So, for example, you want to say they may have been to the toilet, you want them to get help. Just say, oh, look, you are a bit wobbly at the moment, and we really want to help you do this to keep you safe in the early stages. We're all here to help. So you're just trying to help them get around points of barriers and reframe into a positive action. What are our key barriers that need us to talk to patients, that need us to give that education? We know our patients say no one knows there's a risk of falling. So that's the first thing we need to tell them. Remember, our patients have told us very clearly in all our focus groups, you don't call nurses because they're busy. So we need to find a way to communicate positively that we want them to call. And remember, we know that falls happen often due to toileting. So we know that we need to think about toileting plans, and we may have different team actions on our wards, which are all fantastic. Like we might have hourly rounding, or we might have teams nursing, or we might have ways that we identify making sure no call bell gets left unanswered over a certain minute. Or so those are all things that are going to help. Let's just summarize up and say to ourselves, why education? It raises awareness, capability, and motivation in patients to help you prevent falls. We know that reviews demonstrate that older people consistently underestimate their own risk of falls in hospital. So we've got to tell them about it. We know we have good evidence that patients feel deterred from asking for help. They don't feel motivated, they feel the opposite. And let's remind ourselves that the actions, talking to patients, the actions required for safety depend on the patient engaging in the actions you want them to, because 80% of falls happen when no one's in the room. So to keep your ward safe, you need as many people as you can persuade to ring the bell so that you know when people need help. That's the ultimate answer. And you need lots of brochures, flyers, videos, and motivated people and families that understand that concept. You need that. Interestingly, that's the way you also are going to help people raise their mobility, which is the other issue. Again, we were not talking today, but about mobility, functional decline. So getting people to understand what they should be doing and orientating them, giving them that motivation is going to help you help them get out of bed and get going. So let's just remember that our patient is central to the team. Without communicating with the patient, giving them education and repeating falls prevention information, we're not going to succeed in reducing falls on our wards. To do that, we're going to need to know their cultural background, figure out if they're understanding us by asking open-ended questions, understand their cognition, explain things simply. We're going to need to communicate regularly, because remember, patients' communication will vary. We want to pick up straight away if someone's getting delirious and they're no longer able to listen to our messages. We know that we need toileting plans. We know that we really need those. We know that we need a personalized approach to the patient and a good environment. And then we know that the communication has to revolve around huddles, handovers, and teamwork, because we've all got to communicate between ourselves as well, so that we're sure that a really good message gets to the patient every shift, every time, and that we're all delivering the same care. That can be a challenging effort, but we've got amazing wards and amazing places. And in the super pit of your wards, I'm sure you can build that culture that allows that to happen. So thank you for for listening to me, everyone. I know I've been talking a while, and I hope I can get off my screen and still be able to see Teams to pick up any questions.
Okay, thank you, Anne-Marie, for a fantastic presentation. It was great to hear the feedback provided from the staff and patients as part of your research projects, and to see that there is evidence for communication and that education can be effective to prevent falls. We are open for questions now, so please feel free to write them down or raise your hand. As a reminder, this webinar is also being recorded, and we'll upload it onto our Falls Network website and our YouTube page after the event. I might start off with the one in the chat. Karen mentioned that she was interested in incorporating the Safe Recovery Program in her aged care ward. Where can she get more information about this program?
Oh, we have there's a lot of publications on it, so you can have a look at those. We've placed all the videos, including translated versions, on my YouTube channel. So you can go straight to those and you can download the videos and use them. You would be it'd be useful for you to download the brochures that go with them to use. And one thing I do emphasize is ours, I feel, are a little bit local they're made in WA, and that's a little bit of an element. And so feel free to, obviously you might like to adapt them or make something different yourself. But the messages are really important, and we're working out how we can be sure to get a consistent message to everyone. And that's one really good way to do.
Perfect. Thank you. And another question from the chat. Do you have any tips on fall prevention in psych patients? I think in these settings where there's no call bells in the units or consumers may not be open to education or decline supervision in the bathroom.
Yes, I have worked in a psych unit and done some falls auditing there. And one of the most useful things that we've found is examining carefully the medication regimes people are on is one. I wouldn't say it's the only thing, but one really important factor is looking at behavioral charts and falls medication and doing a little bit of balancing between what a person gets put on, and then that can often affect their falls risk. So having some alerts and telling the patient, sometimes you can just give the patient information tactfully, even a brochure or a notice on a wall that says, like a good message for in a psych ward might be just to say, if you take, when you are prescribed new medications, you may notice you feel drowsy or dizzy. Please let us know, as that could be a risk of falls, and we'd like to help you. So just sort of putting it in a non-pushy way. But we did notice that there was a consistent medications got prescribed, and there wasn't a link. Then there wasn't an obvious link staff were making between falls happening. So that'd be one suggestion I'd make.
Okay, thank you. And another question from the chat. Have you ever come across any concerns ethically from displaying a fall risk status? And maybe linked to that, I had a question, is it a case of kind of considering everyone as being at risk of having a fall and having that chat?
Yeah, I don't have an ethical issue because I don't think that you should display it because I don't think that it's relevant. And the reason is that the issue with a falls risk status is it changes its context throughout the day. Any one patient can go from being at almost a low risk to a very high risk, or a high risk to a low risk. I think what's better to display is the actions the patient should have. So, the things that I think is ethical to display is to display like a little sticker of a walking frame showing this patient should always mobilize with a walking frame, or a sticker of someone on, like if you've got a walking frame, a sticker of someone on it showing two people, this patient should always be walking with help. So I would suggest, and we try to put the patient's plan by the bed on a little piece of paper for them. It's a small handout saying, ring bell for any time, ring bell, so I'd suggest rather than displaying risk factors, display the solutions for the patient.
Good advice there. And maybe in the interest of time, just one last question. Any quick tips for communication in patients or residents with cognitive impairment, long-term or acute changes?
Sorry I left this out. It's sort of such a big section, and in the end I thought I'd better not start talking about it. Firstly, remember that if you communicate with everyone who can be communicated with on a ward, that will also help the people with cognitive impairment, because the strategies and the balance of the information and the culture of the ward will spread over. So if you develop really good toileting plans, that'll flow on to those people as well. So first thing. Secondly, really helpful to have some training in working with people with cognitive impairment. And so if you haven't had any education on your ward for a while about ways to relate with people with cognitive impairment, really important. Person-centered care, very simple instructions, and making sure everything's set up for the person. Remember, the person with cognitive impairment, it's 50%, 60% body language. So it's almost how you look is going to be whether the person can kind of take on what you're saying. I realize that's a very quick answer.
No, that was great. Thanks, Anne-Marie. So we're just past 2:30 now. So I think we'll probably close the webinar for now. Thanks to everyone who has attended today's webinar, and thanks again to you, Anne-Marie, for providing all your expertise
Thanks,
on this
everyone.
topic.
And good travels with developing your positive culture in your wards for falls prevention.
Awesome. Thank you.